Hi, I'm Heather Fitter. I'm a clinical team leader from the Division of Neurology at the FDA, and I'm going to talk to you today about the approval pathway for migraine and headache products. The views expressed in this presentation are my views and not necessarily an official statement of the Food and Drug Administration. I'm going to focus today on the approval pathways for migraine and cluster headache, because these are two indications that are handled by the Division of Neurology. I'll start with migraine, which is a syndrome that is associated with pain, but it's not just a pain syndrome. There are also other associated symptoms: nausea, photophobia, and phonophobia. And for a drug to be approved for migraine, it has to have an effect on all of these. It has to have an effect on pain as well as the associated symptoms. The International Headache Society put together a classification system for headache disorders. And according to that classification system, for a patient to get a diagnosis of migraine, they have to have at least 5 attacks that fulfill the following 3 categories. The headache should last 4 to 72 hours if untreated. The headache should have at least 2 of the 4 features: unilateral location, pulsating quality, moderate or severe pain intensity, and aggravation by physical activity. And the headache should have at least one of the following 2: nausea and or vomiting, phonophobia, and photophobia. Some patients get an aura, which is a reversible neurologic symptom that normally will occur within 30 minutes of the onset of pain. So products that are marketed for migraine should demonstrate an effect on the CoPrimary, pain freedom, and in the past, we used to have 4 CoPrimaries, so it had to demonstrate an effect on absence of nausea, absence of photophobia, and absence of phonophobia. More recently, after negotiations with industry, we've come to a new endpoint, which is absence of most bothersome symptom. So now the treatment trials for migraine can have a CoPrimary made up of the absence of pain, which is measured on a 4-point scale. And the expectation is that patients will treat their migraine if in the trial, if it has moderate to severe pain, and then at 2 hours, we want to see that they have no pain. In terms of the most bothersome symptom, we ask patients to select whether this is nausea, photophobia, or phonophobia. And then there's 2 ways to design a study to test this. Either patients will identify this at the time of randomization, and then they'll only treat a migraine with the investigational product if it is associated with their most bothersome symptom that was identified at that point. Alternatively, patients can identify their MBS at the time of their migraine, and we just have to be very careful and make sure that it's documented that this is selected prior to taking study drug. In migraine treatment trials, we also like to measure sustained pain-free at 24 or 48 hours. And this is defined as pain-free at 2 hours and every interim assessment until 24 or 48 hours with no relapse of pain and no rescue medication. The other endpoints that I have listed here are endpoints that we also like to see in some of the trials. We're working closely with sponsors on development of clinical outcome assessment tools to assess changes in quality of life or function with treatment. Although we talk about acute treatment of migraine, we consider the treatment of migraine to be chronic intermittent. And the reason why is because many patients don't just take a pill for their migraine once a month or every other month. We know that many patients are taking medications almost daily or every other day. So we require a safety database of 300 patients for 6 months and 100 patients for 1 year. And normally this is obtained from a long-term extension study. These could offered until after the adult drug application is submitted. So in the past 2 years, we've approved 3 new drugs for acute treatment of migraine. 2 are in the calcitonin gene-related peptide antagonist group, and they're oral agents. And 1 is a serotonin agonist, but it's different than the triptans in that it works on different receptor subtypes. And the receptor subtype that we believe is involved in causing coronary vasospasm is not one of those subtypes that this new drug works on. So we think that it may be safer in patients that have cardiovascular risk factors. So much of what I just said is summarized in a guidance for industry that we updated in February 2018. So some patients are taking medication frequently, and they may be candidates for preventive treatment. And this can depend on the number of days that they're having migraines, the severity of the migraine, or the amount that those migraines affect their daily life. We ask sponsors to study these 2 populations separately. Episodic migraine, which is defined as less than or equal to 14 headache days a month, and chronic migraine, which is defined as greater than or equal to 15 headache days a month, where 8 of these are migraine, and this has been going on for greater than 3 months. We believe that there's different characteristics of these headaches and that there may be different treatment effects. So patients that are taking a lot of acute migraine medication may develop medication overuse headache. And this is defined as a headache occurring on greater than or equal to 15 days a month in a patient with a pre-existing primary headache, and a patient that regularly overuses acute headache medication for more than 3 months. So what we end up seeing is, as a patient is taking more and more of these medications, they're getting more days with headache rather than less. And we see this with over-the-counter analgesics, prescription migraine medication, as well as prescription analgesics. And this is something we certainly want to avoid. So in the preventive treatment of migraine trials, we like to see a primary endpoint of change from baseline in monthly migraine days over a 12-week period, or change from baseline in monthly headache days over a 12-week period. We also like to see the measurement of the use of rescue medication so we can see if there's a reduction of this, and the 50% responder rate compared between treatment groups. In the past 3 years, we've actually approved 4 new medications for the preventive treatment of migraine. They're all biologics, they're injectable, and they're in the calcitonin gene-related peptide category, in that class of drugs. So they're all monoclonal antibodies. And the treatment effect that we've seen is about a reduction of 1 to 2 migraine days a month, which may seem relatively modest, but that's why I want to show you the next slide, which is a figure that we have in the label of Aimovig, which is the first of its class that was approved. And you can see that there is a subgroup of patients that have a higher treatment effect. But we are not able to prospectively identify these patients. So trial and error is the way you can see which patient's going to have a greater response. I also want to point out in the slide that in migraine trials, we often have a high placebo response. And you can see that here. And this is one of the reasons it's so important to have an appropriate comparator in these trials. I'm going to switch gears to acute treatment of cluster headache. Cluster is defined as a severe or very severe unilateral, orbital, supraorbital, and/or temporal pain lasting 15 to 180 minutes that's associated with either or both. The first bullet are signs that we see with sympathetic nervous system dysfunction. So you may see any one of these: conjunctival injection, facial sweating, meiosis or ptosis, to name a few, and a sense of restlessness. The frequency varies. You might see one every other day, or some patients may have 8 per day, but there's a circadian rhythm associated with this, and they often occur at the same time. The primary outcome has to consider the fact that there's so much variable. There's so much variability between individuals. So we don't want to measure the natural history of a cluster and just, follow a patient until their cluster would naturally resolve. So we pick an early time point for the primary endpoint. What we like to see is pain relief at 15 minutes, sustained 1 to 2 hours. You can see with cluster, we want to see that patients are getting pain relief because this is such a severe pain that they have with this type of headache. So we've polled patients that have cluster headache, and what we've heard is that pain relief at 15 minutes is satisfactory. With migraine, as you saw, we ask that products be able to achieve pain-free at 2 hours. And this was based on also getting community input and asking migraine patients about what it is that they think they should get out of a drug for migraine, and they said that the expectation was that they would be pain-free. So although in the past we had primary endpoints related to pain relief, now we ask sponsors to demonstrate that their product can make people pain-free at 2 hours. So when sponsors are studying treatment of cluster headache and they're trying to evaluate how to have a cluster period stop or reduce the number of clusters that the number of attacks that patients are having, they will study these 2 subgroups. Episodic is defined as patients that have at least a 3-month pain-free period, whereas chronic cluster headache patients don't have that 3-month period. We don't have as standardized an approach to studying cluster headache as we do for migraine. So there are several primary endpoints that we find acceptable for studying episodic cluster. A reduction in weekly cluster headache attacks over 2, 3, or 4 weeks. And the goal here, and the reason there's variability here, is it's hard to predict how long a patient's cluster will last. And so the goal is to capture that before the cluster resolves so we can see a treatment effect. The primary endpoint for chronic cluster studies is reduction in weekly cluster headache attack from baseline over a 12-week period. In conclusion, we have standardized approaches to study acute migraine and the preventive treatment of migraine. We're working with sponsors to develop study designs for other headache types where there's less standardization, such as cluster headache. We've had a very productive 3 years, but we still have more work to do to provide more therapies to patients with migraine and headache disorders. Thank you for your attention.